I think we can start going forward. Sam, can you hear me okay there?
I can hear you.
Okay. Well, it's that time. I'd like to welcome everyone to this COVID-19 lecture on active surveillance. Who would have known 3 months ago that we'd be in a situation like we're in right now? I hope you're all safe, you and your families. I'm going to talk to you today about active surveillance for early stage prostate cancer, the future or the past. Active surveillance is a response, in my mind, to overdetection and treatment of prostate cancer brought about by widespread and repeated PSA testing that occurred in the early to mid-90s. I also think it's important to realize that the uptake by the urology community of active surveillance helped pave the way for an upgraded assessment by the U.S. Preventive Task Force on early detection of prostate cancer. As you recall, the task force changed their recommendation in 2012 to a grade D recommendation. We saw rates of early detection plummet, and if you may have read recently, the thought is that that may have resulted in increased risk of advanced prostate cancer. So today I'll talk to you a little bit about surveillance. Now, before I do that, I'd like to make an editorial comment that even though I'm telling you here that we overtreat prostate cancer, at the same time, I think we undertreat it. I think we undertreat high-risk prostate cancer. I'm a very busy surgeon. I continue to operate many days during the week and think that radical prostatectomy or radiation is preferred form of treatment for many men, but it is not the only form of treatment, and it does not need to be considered in all men. So the goals of active surveillance are to avoid or delay the cost, functional and monetary of treatment without compromising cancer cure. It's compliant with all North American and European screening and treatment guidelines. It's based on the rationale that initial assessment is reasonably accurate. Monitoring is accurate and identifies subclinical progression at a time the initial treatment options are still available and curative. I want to point out also that surveillance, as I'll show you, is about timing of treatment. Do all patients need to be treated right now? It is true that by 10 years, 50% of patients on active surveillance will require treatment. The key is, can you avoid any side effects of treatment and still treat the patient for cure when that time becomes optimal. So the data I'm going to show you today is based on our experience at UCSF. I'll refer to a few cohorts towards the other cohorts at the end, but this is based on our experience with about 2,100 men. The year of diagnosis, the median is 2010, but I have patients going back to 1990. The age of diagnosis is around 62 years old. PSA at diagnosis 5.5. These patients have been followed for a median of 73 months. About 85% of our cohort started out as low risk, about 15% intermediate risk. So we actually accrued at UCSF some patients with higher grade cancers. Just to cut to the chase here, this is the upgrade-free survival at 7 years. So this is patients who were enrolled on surveillance, underwent serial biopsy, and had any change in grade at 7 years. So 41% upgrade-free survival at 7 years. So the majority of patients actually show some change in grade or volume at 7 years time. If you look at upgrade-free survival for 3-3 versus 3-4, now again, you're going from a 3-3 to a 3-4 here, or a 3-4 to a primary pattern 4-5, very similar at 7 years follow-up, about 50 to 60%. Treatment-free survival, however, at 7 years was 59%, so about 41% of patients required treatment. Now, why the discrepancy between upgrade and treatment? Again, a lower treatment rate compared to upgrade rate. And the reason for that is here, if we look at the change in grade or volume, what I'm showing you here is a CAPRA score, going up or low. And for those who don't use CAPRA, it was a score system developed here at UCSF, a multi-variable risk assessment scheme, validated in tens of thousands of patients around the world, predicts biochemical recurrence after surgery or radiation, actually also predicts overall and prostate cancer specific survival. So I'm showing you here is, again, on any biopsy, about 17% of patients will have a negative biopsy. And if you look at change in risk over time, only about 20% of patients have a substantial change in risk over time. So most of the time, if you see a change in volume or grade, it's relatively limited. So that's why not all patients who showed a change in grade or volume were treated at UCSF. Some who showed very minor changes in volume or grade actually stayed on surveillance, but about, again, 15% had substantial changes in volume or grade necessitating treatment. So treatment-free survival, again, is a little bit more likely in those with low-grade disease compared to higher-grade disease. I'll get into this a bit later when I talk about some of the controversies of active surveillance. So again, if you start out with a 3-4, you're more likely to be treated at 7 years compared to those with a 3-3 cancer. The overall survival at 7 to 10 years is 96%. Prostate cancer-specific survival is 99%. We've had very few people with metastases, and most all of these were lymph node metastases, and frequently in people who were not compliant with surveillance. People who I may have seen 10 years ago really fell off screening and surveillance and came back much later, but about 6 cases with the metastases. Okay, what about deferred treatment, outcome after delayed radical prostatectomy? So this is what I'm showing you here, and again, this has all been published. These are the pathology results in men who underwent delayed radical prostatectomy, and this is based on a cohort of about 460 patients who progressed in surveillance who I took to surgery. About 45% had any adverse pathology, either primary pattern 4 or 5 or T3 disease. As I'll show you a bit later, the overall PSA-free survival, second treatment-free survival, was actually quite good. But of these 460 men out of 2,000, a little over 2,000, went to surgery, about 45% will have any adverse pathology. What about the impact of new technology? A lot's changed in surveillance. So we've seen the uptake of genomic testing and multiparametric MR imaging with time. Now, the NCTN recommends genomic testing in those with low and intermediate risk disease will be considered for active surveillance. Actually, in very low risk patients, a low PSA density, low volume, low grade disease, they tend not to be very helpful, but they can be helpful to discriminate patients in the low and intermediate risk categories. Several tests available, and this is in the NCCN guidelines. All these assays have prognostic value. They're not predictive, so they don't predict a response to radiation or surgery. They have prognostic value, and the most common commercial tests are Decipher, GPS, or Oncotype, and Polaris. I think they all predict. Here at UCSF, we've actually validated all 3 of these, and I'm going to just show you one example, but I could have chosen any one of those as an example. This is the Oncotype or GPS. This is a quantitative 17-gene RT-PCR assay. It's done on tissue dissected from the paraffin block. You can get actually a good reading on maybe 1 to 2 millimeters of tissue. It's very remarkable. And these are the categories or the pathways that this test was based on. And again, this is work that was done here at UCSF in conjunction with the Cleveland Clinic. What I'm showing you here is important in that if you look at the Capra score and you correlate it with GPS, it's actually a weak correlation. And that's very important. If you have a test that correlates with Gleason grades very well, then it's not likely to provide any additional information. I review a lot of grants where people want to look at a genomic score and see how it relates to Gleason grade, but you already know Gleason grade. So when you see a test does not correlate with a known predictor, it's telling you that it may be offering some independent prognostic information. And here on this slide, I'm showing you the likelihood of favorable pathology. These are people who had a biopsy done, was thought to represent low-risk disease, who I took to surgery. So we're testing the hypothesis that the genomic score in the biopsy predicted the likelihood of adverse pathology at the time of radical prostatectomy. Again, predicting that those patients actually were harboring higher risk disease. And this is likelihood of favorable pathology for a Capra 0, again, a very favorable patient, down to Capra 4 here. So the risk of a favorable pathology actually varies between these categories. Now, if you add genomic testing, you can see that in each individual Capra score, you further substratify the patients into higher or lower risk patients. So it's saying for these known variables, when you add the Oncotype score, it's telling you how are you higher or lower risk. And when you do this, you can actually increase the number of patients who might be candidates for surveillance. Sometimes the test shows more favorable results, some less favorable results. So we looked at the GPS score and upgrade on surveillance, and it turns out that the GPS score for every 5 units in a multivariable model, it predicts for upgrading on surveillance. And this again, in the model, we have PSA density, age, and biopsy volume. And when you look at adverse pathology again, impact on adverse pathology and PSA relapse, you can say the same thing, that this is PSA relapse after surgery. The GPS score predicts for either adverse pathology or actually biochemical recurrence following delayed radical prostatectomy. Again, these are all multivariable models. This is an important slide because I'm showing you a waterfall plot here. Blue is upgrade and red is no upgrade. And I can show you a similar waterfall plot for PSA recurrence. What this is showing you here as you increase the GPS score, you actually have a higher risk of an upgrade. But there is no GPS score that completely excludes or predicts progression. So you use this test in conjunction with all other pathologic variables that you're looking at. So again, no single GPS test is a yes or no. It's assessing risk further. So some of the concerns about genomic classifiers or tumor heterogeneity, that seems to be less of a problem in prostate cancer compared to a cancer like renal cancer. Do all patients benefit? As I told you, probably not very low risk patients. I think those in low and favorable intermediate risk patients are probably better candidates for this. That's where you see the most variability in genomic testing. Are they cost effective? What are the long-term outcomes? And of course, there are randomized trials that are testing these hypotheses now. There are other biomarkers, and the issue is there are other biomarkers. One's PSA density. Again, PSA density over 0.15 is a strong predictor of progression on surveillance. We've looked at this several times over the last several years. Again, PSA density below 0.1 is best, but again, below 0.1, between 0.1 and 0.15, and over 0.15, these are all predictive cut points. Very easy to do, doesn't require any extra expense, but PSA density is a strong predictor of progression on surveillance. This is work by Carroll at UCSF, just showing the, sorry for the lightness of these lines here, but to show the impact of a negative biopsy. It turns out that at any single biopsy done over time, about 20% of patients will have a negative biopsy. And again, a negative biopsy, as you'd expect, is a strong predictor of non-progression. If you had more than 2 negative biopsies, even less likely to progress over time. On the internet, there's a lot of chatter about so-called vanishing prostate cancer, and it turns out that we think the cancers don't vanish, they hide, but we've seen some patients who've had 2 negative biopsies down the line have a 3rd, 4th, or 5th biopsy, and you'll find cancer, again, usually of low grade. So again, I think this is an artifact of detection, but a negative biopsy is a strong predictor of non-progression. PI-RADS score and upgrade on surveillance. It is true those with a high PI-RADS score are more likely to progress on surveillance. When we actually look at PI-RADS scores in a model that includes genomic markers, the PI-RADS score drops out, genomic markers stay in, but again, high PI-RADS score tends to predict for higher risk disease. Carissa Chu at UCSF has looked at this, and we've seen that on serial MRI, actually changes in MRI are relatively common. PI-RADS 4 or 5 or any increase in PI-RADS predicts progression over time. So if you go from a PI-RADS 1, 2, or 3 to a PI-RADS 4 or 5, obviously that predicts progression. But any patient who enters surveillance with a high PI-RADS score has higher risk disease. Again, it doesn't say that the PI-RADS score in of itself should be an indicator for treatment, but it may be the patient who will need an early confirmatory biopsy. Similar to you'll find with genomic testing, if you have a patient who seems to be a good candidate for surveillance, but has again, an adverse PI-RADS score, adverse genomics, doesn't mean you need to treat them, but you should at least consider an early confirmatory biopsy. Current controversies with surveillance or what risk categories are appropriate, very low, low risk, low CAPRA scores. What about Gleason 3-4 disease? It is safe in African-American men, and are younger men appropriate candidates for surveillance? A lot of series around the United States, or a lot of practices, will not consider surveillance in younger patients. It turns out at UCSF, we have a lot of younger men on surveillance. I see a lot of patients who have not completed their families, may have had the diagnosis by serendipity. By that I mean had an elevated PSA, had a biopsy, repeat PSA is actually normal, or has a biopsy for an abnormal digital rectal examination, and lo and behold, the biopsy shows something on the contralateral side. That's what I call serendipity. So we actually looked at this UCSF and published this a while back, and 3- and 5-year upgrade-free survival are more favorable in younger patients. And actually, we've really known this over time. Younger patients have less adverse features or less aggressive cancers compared to older patients. In fact, older men are more likely to have adverse pathology on delayed radical prostatectomy compared to younger patients. And on a multivariable model, young men had a lower likelihood of upgrade on surveillance. And there's no significant association between younger age and time to treatment or biochemical recurrence. So again, younger patients have slower rates of progression, and I think remain good candidates for surveillance if all other features appear to be favorable. Now, obviously, if you have a younger patient, they're more likely to require treatment over time, but in fact, that does not mean that they need to be treated immediately. What about African-American men? Data from 2 large registries, Capture, UCSF, and Search, showed African-American race was not associated with upgrade or upstage, and there was no significant association between African-American ethnicity and pathologic upgrade, upstage, or positive surgical margins. But I want to point out that there are a few African-American men in the current cohort. So I don't think African-American men should be necessarily treated based on ethnicity, but we do need to disclose that all large North American and European cohorts on surveillance have actually relatively limited number of men of African-American ethnicity. This is recent work, and I apologize for the figures here, but this is recent work from the Canary Consortium, of which we're a part of, that showed African-American race is not associated with increased risk of reclassification or treatment on Canary. But again, I want to point out here that there are few African-American men in this cohort, and that we did not do admixture studies in these patients. Again, this thought that when you African-American men, that they may be Caribbean descent, and others may have higher risk categories than men. So we actually have to take these results with caution. But again, I think African-American men are still candidates for surveillance. What about Gleason 3-4 disease? In urology, we've drawn this line in the sand. We've been hostage by cancer grade. That so if you go from a 3-3 to 3-4, it's like falling off a cliff. You go from insignificant to significant disease. But I want to point out that cancer risk is best assessed with multivariable instruments, not a single variable like cancer 3-4. In CAPRA score, going from having a Gleason 3-4 disease adds only 1 point to a CAPRA score between 0 and 10. And as I'll show you, it's actually volume rather than grade alone, which is a predictor of adverse pathology. And when you look at men who want to go immediate versus delayed surgery for Gleason 3-4 disease, the outcomes appear to be very similar. And that's been our experience at UCSF and a large cohort of men who've undergone surgery. So again, I showed you this earlier. So if you take patients with 3-3 versus 3-4 disease, it is more likely that those with 3-4 disease will require treatment at 7 years' time. And you need to disclose that to patients. Recurrence-free, this is actually not only biochemical recurrence-free survival, but actually second treatment. So the bars are rather high here. So if patients got any second treatment or had biochemical recurrence, they were scored as such. And it shows a little difference between PSA recurrence-free survival with delayed radical prostatectomy for those with 3-4, 3-3 disease who are upgraded over time. Again, look at modeling. It turns out that grade alone does not predict, but it's actually volume. So those with a single core low volume 3-4 disease showed no increased risk of progression of biochemical failure afterwards. So when we look at 3-4, you really need to look at volume of disease, not just having 3-4 disease. Another very important point, and if your pathologists are not doing this, they should, you can actually substratify Gleason grade 4 disease in different histologic subtypes: expansile cribriform, polyform, fused, glomerulation, and stromal reaction. So when you get a pathology report back, it turns out that these histologic subtypes are strong predictors of outcome, whether it be progression on surveillance or actually recurrence after surgery or radiation therapy. Again, nice work from UCSF showed that cribriform histology, actually expansile cribriform histology, and stromal reaction are associated with higher genomic scores and a higher risk of adverse pathology and likely biochemical recurrence. So again, try and get your pathologist to stratify Gleason grade subtype. And again, these different subtypes correlate with the genomic score. So again, this is easy information to get, which does not require any additional expense on the patients or the systems at all. So active surveillance of Gleason 3-4, caution those with high PSA density, PIRADS 4 or 5 and multiparametric MRI, adverse genomics, GPS, Polaris or Decipher, cribriform or expansile cribriform histology, and again, this whole issue of volume. So a larger number of biopsy cores positive diagnosis tends to predict for progression. I think we need to make active surveillance less burdensome. You know, we need to get away from, you know, standard biopsies every year. And I think we can do this. Again, the patients who you should consider for treatment or early confirmatory biopsy are those who have higher volume, higher grade disease, high genomics, PIRADS 4 or 5, cribriform histology. These patients we would rebiopsy within 6 months' time, as opposed to patients with favorable PSA density, favorable volume, low-grade disease, favorable genomics, favorable MRI. These are patients we'd reassess at 12 to 18 months. Again, obviously, any patient in poor health should be on watchful waiting. I'm seeing a patient later today, age 95. Someone got a PSA on him at 33. We'll actually probably just watch this patient. He's actually in good health, but that patient I don't think needs advanced imaging or genomics. The less intense surveillance are those with low PSA density, negative biopsy, favorable MRI, and genomics. Again, we're working with many to develop new signatures detected in the urine or serum, which may substitute for biopsy. So we're really trying to get away from routine biopsy and want to go to less burdensome surveillance strategies. This work by Peter Lonergan, one of our fellows, which is in press currently, showing what risk factors for biopsy reclassification on surveillance, and actually it's PSA density, biopsy cores, positive, higher genomic scores. These patients are at risk for early reclassification. It turns out that PSA kinetics, PSAs are actually very stable early on in surveillance. They tend to play a role when you get out beyond 3 to 5 years, when they tend to predict for delayed progression over time. Again, PIRADS scores dropped out of the analysis here when we had genomic scores in it. But if you're not using genomic scores, PIRADS scores would be a predictor as well. Well, UCSF is just one cohort. There are others from Europe, PREA study, here in the US, Canary, Johns Hopkins, Toronto. It's important to realize that all these cohorts are a bit different inclusion criteria. So Toronto and UCSF tend to be a little higher risk population compared to Johns Hopkins, the European cohorts, and Canary studies. But the reclassification risk over time is similar, again, between 20 and 40%. Treatment at 7 years, again, relatively varying between 50% to a bit higher at 10 years' time. Metastases, very, very rare event, again, between 0.1 and 2.8% over 15 years' time. I think it's very important for all of you, when you look at these results, try and get a sense about what your cohort looks like. Is it only very favorable patients, or do you have some patients with higher risk disease? And then you can interpret these results a bit better. Our practice pattern is changing over time based on surveillance. While this is at UCSF, you know, I'm showing you low, intermediate, and high risk patients over time. This is a radical prostatectomy series. And again, what we're operating on at UCSF now is not low risk patients. In fact, at UCSF now, it's very rare you'll see a low risk patient undergoing surgery. That varies across the country, as I'll show you. Here at UCSF, the only patients undergoing surgery for low-risk disease are generally those with adverse genomics, you know, BRCA2 patients, things like this. But we actually have gone from treating low-risk patients to treating actually high-risk patients here at UCSF. And if you look at CAPRA, clinical risk by diagnosis and surveillance over time, you see here we're actually having more and more higher risk patients on surveillance at UCSF. These are what I mean by higher risk, generally intermediate risk patients. We have very few high risk patients on surveillance. Nice work by Sam Washington, my moderator today, showing you, this is SEER data, showing you the rates of active surveillance in red, surgery in blue, radiation in green here around the country. The highest rates of surveillance actually are here in San Francisco, but you can see actually relatively low rates of surveillance for low-risk patients over time. So we have considerable variability in the use of surveillance across this country, which is a little bit puzzling and worrisome for me. So when you see variability like this, you like to understand it, but we see this over time, and it's important to look in your community to see where you stack up compared to others. New developments, I think a couple of things you need to understand here is, you know, 20 years ago, we detected all patients, we treated all patients. Then we continued aggressive screening, but we treated more selectively. So we went to the era of active surveillance. I think where we're moving now is trying to avoid the detection of low-risk disease. So instead of having elevated PSA, and I always want to point out to people, if you have a patient with elevated PSA, the first thing you do is don't get an MRI, you need to repeat the PSA. So you want to validate the PSA is truly elevated. And although you can consider doing a biopsy in a patient with elevated PSA, you can also consider using biomarkers that improve the specificity of screening, the likelihood of detecting higher grade disease, and it can be done with both urine and serum biomarkers, and there are several currently available to do this, or a multiparametric MRI. So what we're seeing now is, instead of going right to a biopsy with an elevated PSA, to secondarily screen that patient with serum or urine biomarkers or an MRI. And there's a lot of discussion right now as if you do the serum markers or go right to an MRI. They suggest that you could actually probably get the serum or urine biomarkers first, and then consider the multiparametric MRI in higher risk patients that would allow for a targeted biopsy. Work done by Claire Delacaille at UCSF and Hao Win, so that even when you use markers of specificity, you'll still detect about, even though you'll decrease biopsy rates by about 20 to 40% by using these tests, still about 30% of the patients you detect have low-risk disease. So even though you're decreasing the overall cohort of men with low-risk disease, you're still detecting such patients. What I've seen actually now around the world is the thought that focal therapy to be used in lieu of active surveillance, either time of initial diagnosis or in those people who progress on active surveillance. Victoria Fasulo recently looked at this at UCSF. You know, we recognize that active surveillance can be burdensome for some patients. Active surveillance may not be practical in patients who do not have the local resources for surveillance. And I'm talking about developing countries. You know, in China, when I was lecturing in November, when I gave a talk on surveillance, someone raised their hand, a very well-known urologist, and said, "Gee, Peter, that surveillance may actually work well in the United States, but in China, where people come from a long distance to get their care, where there may be not local resources to do surveillance safely, or where it may not be acceptable for some patients, these patients may be considered for focal therapy." And again, even here in the US, 10% of our patients on surveillance who have not progressed find surveillance burdensome. And the thought is that focal therapy may be less morbid than whole gland treatment. Again, data from UCSF Dr. Vasulo showed that you do not want to make the decision about focality on a single biopsy. You actually need at least 2 biopsies before you can consider it. And then actually in the series at UCSF, about 63% of patients who've undergone 2 biopsies may be considered candidates for focal therapy. And by focal therapy, I'm talking about either sub-hemigland treatment or hemigland treatment. So actually, it may be that there are candidates for focal therapy that can be gleaned from a cohort of men on surveillance. And this work is under review right now. So in summary, I think active surveillance is the preferred form of treatment for men with very low risk and selected patients with favorable intermediate risk disease. I do think that new technology, MRI and genomics, appears to make it safer. Its use remains highly variable in the US, and I think urologists have to be very cautious about this. Again, one of the reasons why the task force changed their recommendation for screening from a D to a C is not only based on the fact that they reinterpreted data on the randomized trials, but also because they understood that surveillance in lieu of immediate treatment was being offered to US men. And I do think that active surveillance will be challenged by new forms of focal therapy going forward. With that, I'll close, and I think, Sam, or do we have any questions or any questions from those listening?
Yeah, it looks like we have a few questions on the Q&A board. The first was, how do we incorporate MRI into our active surveillance algorithm?
So I'll say what we do at UCSF, and I'd also like to acknowledge Sam Washington. I should have introduced him as a fellow here at UCSF, but I'm proud to say within a month's time will be a faculty member at UCSF. So Sam, thank you very much. He's contributed to a lot of this work right here. So what we do, I think we incorporate MRI, and again, endorectal MR imaging was developed at UCSF over 20 years ago. We've done over 20,000 scans over time, and been continuously funded for MR work by the NIH over this last 2 decades time. So MRI is something near and dear to our hearts. We no longer do endorectal imaging. We do the body coil imaging, multiparametric MRI, the high-res definition. Right now, we're using it in men at the time of diagnosis. So we actually try and do an MR-guided biopsy to begin with. MR guidance may compensate for any problem with expertise on the basis of the provider. So we'll do an MRI at the time of initial diagnosis. If we see people who appear to be candidates for surveillance who have not undergone MR imaging, we'll go ahead and get it done. So again, to look for, I'm seeing a patient later today on video visit who had a single core of Gleason 3-3 disease, but had a high PSA density, hadn't had MRI. We got an MRI, shows a large anterior lesion, which I think was missed on biopsy. So we'll consider early confirmatory biopsy. If you have a patient who has low risk disease, low PSA density, we get an MRI, it's favorable. We won't get an early confirmatory biopsy. We'll generally consider repeat imaging at 12 to 18 months with a delayed confirmatory biopsy. So that's how we incorporate MR imaging. We do it over time. We don't do it every year. We'll probably do it at 24 months and then make a decision on further biopsies down the line beyond the confirmatory biopsy based on their PSA density over time, their PSA kinetics, and their MRI. So if they have a favorable MRI that's maintained over time and they've undergone a confirmatory biopsy which is favorable, we'll consider a delayed biopsy.
Next question had a few parts. So one, what would you consider a substantial change in grade or volume in an active surveillance patient? How do you make that determination, and what is taken into account?
So what we look at is grade, histologic subtype of pattern 4, and volume. So again, the patients who you could tolerate to be on surveillance with higher grade disease are generally those with limited volume, 1 or 2 cores, and not multiple cores. If they have multiple cores of 3-4 disease, these patients have higher risk disease. Any histologic subtype, expansile cribriform, or again, those who have genomic profiling which is adverse. If you look at genomic profiling over time, most people's genomic scores will stay actually quite stable over time. We see a small number that actually have increasing genomic scores.
Our next question is, what do you do if people have multiple negative biopsies? Do you stop biopsying? Do you just follow PSA?
Yeah, if they've multiple, I think the first thing is, did you do your best to identify higher risk disease? So I think if you have a negative biopsy, before going to another biopsy, these are patients who are good candidates for 4K, prostate health index, select MDX. So there's a lot of tests can be done. I run the NCTN panel on early detection. So if you have a negative biopsy, before going to another biopsy, this patient should be screened with these tests of specificity and also an MRI. So again, I don't think you should do repeat biopsies in the absence of new technology. But if you have a favorable MRI and a favorable 4K test, I don't think that patient needs to undergo repeated biopsy. You have to have a reason for it.
There was a similar question asking the role for MRI targeted biopsy throughout the course of active surveillance. Is it treated differently, or is a patient treated differently if they were upgraded on a targeted biopsy, but systematic biopsy did not show upgrade?
Yeah, this is an important point. Realize that the negative predictive value of an MRI is about 85%. So if you used MR alone to determine whether you did a biopsy, you'll miss about 15% of men with higher risk disease. So if you have a negative MRI, you need another test, either PSA density or something else for a case score before you don't biopsy that patient. So I think an MRI alone should not be the determination. A negative MRI alone, to me, is not adequate not to do a biopsy. So again, we see that about 15% of patients who are upgraded over time do so outside the target. So again, at least for the first repeat biopsy, you need to do systematic and targeted cores. I am a little worried about oversampling. So if your criteria for surveillance is based on volume alone, be careful about repeated sampling. If you take 2 cores from the target, you won't change your outcome. But if you repeatedly target the you take, sometimes I see people get 6 cores taken from the target, and if you have a volume threshold, you frequently exceed it. So again, I look at this issue of oversampling. I think if you take 2 cores, you're going to be okay, but if you start taking repeated cores from the target, I think you're at risk for what I call oversampling. And again, be mindful of this issue that there may be candidates who actually have very focal disease. So again, I think when you do this additional biopsies, look at grade, volume, and focality before you make a decision about treatment.
And I know we look at PSA density at diagnosis, but one attendee is asking, can you talk more about PSA kinetics and what your thresholds are?
Yeah, I think you have to be careful for PSA kinetics at low PSAs. PSA kinetics only work over many long periods of time. So what we have found is that PSA appears to be very stable early on, and only maybe a marker of progression over time and not initially. So be very careful. You can only set PSA kinetics with doing repeated PSA measurements. So if your PSA is rising, you have a PSA that's going up, don't go to treatment right away, get another PSA. So at low PSA values, we see a lot of noise in serial PSA testing. So again, it only over time with repeated PSA measurements does appear to be predictive. Sam, is there any additional questions from anybody?
Going to check to see. I think we are. That is the in for our questions. Oh, there is one more that came in. Can you comment on active surveillance and its impact on sexual function?
So what we have found, I think the real issue is this: sexual function in men declines with age. So it's a natural tendency on surveillance to see some change in sexual function, but that matches a cohort effect of men without prostate cancer. I think one of the questions was, does repeated biopsy impact sexual function? And when we looked at this, we did not see that a biopsy in of itself had an impact on sexual function. In fact, it was this, the natural decline in sexual function occurs with men over time. But there are other reasons to avoid a biopsy. No one likes it. But we don't think that surveillance itself has an impact on function. What I hear a lot is this issue that if you operate on men who are younger, they do better. And that's true, but it is true because they start out better. We've actually looked at this in capture over time. And it turns out that if you look at the actual percent decline in function that occurs, it really is no different between younger and older patients. It turns out that younger patients tend to have a better function to begin with. So we don't say to patients, go ahead and get treated now because you're in better health. It's a so-called prophylactic radical prostatectomy. I would not advise that. Younger patients start out better, that's why they do better. But the actual percent decline is very similar between younger patients and older patients.
Can you talk a little bit about diet, exercise, interventions for men on active surveillance and how we incorporate that into our practice?
Yeah, a great question, great question. And we've done a lot of work on, in the early years of Dean Ornish on diet, and now we've gone to diet and exercise. And I think there's a strong rationale for considering dietary changes and exercise changes in men. One, in this country, we have an epidemic of obesity. And so I think, we don't need to use prostate cancer diagnosis as the only rationale for dietary or exercise changes, but I would strongly consider it. And we have a lot of clinical trials now, both for diet and exercise. Exercise, interesting enough, and if you'd asked me 10 years ago, and I'm an avid runner and cyclist, but if you'd asked me 10 years ago, do I think that exercise would have been something we do for cancer diagnosis, I would not have expected, but actually there's a strong rationale for this. And actually work at UCSF suggests that changes in diet and exercise may, in population-based studies, work with June Chan and Stacy Kenfield here at UCSF, suggests you may actually decrease recurrence rates by adopting better lifestyle changes. So again, you can go to our website and others, we have PDFs on diet and exercise, but it appears that this is something that should be considered. It actually is obviously heart healthy, so when men change their diets, we see considerable improvement in overall risk with time. So we would consider it. So generally we would go for a heart healthy diet. We think a comprehensive lifestyle change is more important than any single supplement. But it's a great question, and we think a strong role for it. And actually, men who adopt a lifestyle intervention are more compliant on surveillance compared to men who don't adopt a lifestyle intervention.
There's one question looking forward asking, where do you see the future of active surveillance in the next 5 or 10 years?
Well, I hope it doesn't go away. I worry a little bit that, we're judged on how we treat low-risk disease. And if we go back to over-treating low-risk disease, we will be judged harshly. But I think I think we'll see this continued reduction in unnecessary biopsies. Again, so if you take 1,000 U.S. men and screen them with PSA, about 250 will have an elevated PSA. If you biopsy all those patients, about half will not have cancer. Of the half that do, about 40% have low-risk disease. So I think there's a strong rationale to consider markers of specificity. So secondary screening with either urine or serum markers or MRI, I think will become increasingly important, and we'll have a steady reduction in unnecessary biopsies. I think for those low-risk patients who are diagnosed, I hopefully will consider continued active surveillance. It'll be refined. I think will demonstrate the impact of new technology. And again, this whole issue of focal therapy, I want to be sure we use focal therapy in those, we tested well, because focal therapy studies to date have not been done, in my opinion, very well. But I think there may be a role for focal therapy in some of these patients with time.
Perfect. I think that is it about for any questions that we have.
Well, feel free, any of you, to reach out to me, peter.carroll@ucsf.edu. I look forward to seeing all of you post COVID-19. I want to say I personally appreciate the response of the urologic community. We're back in the OR over time. I hope our paths will cross in the future. And when I see you next, hopefully I'll have shorter hair, because the only thing I'm looking forward to is opening those barbershops so I can get a haircut. But please be safe, and thank you for all you do on behalf of urology. And Sam, thank you.
Thanks for including me.
Okay.